You're listening to the Physio Matters Podcast in association with Choose Health, and today sponsored by Rocktape UK, and this is session 12. Welcome back to the Physio Matters Podcast with me, Jack Chew. Thanks as ever to those of you who sent some feedback for session 11 with Seth O'Neill. If you want to formalise your praise or dislike, please drop us a review on iTunes. The key goal of the Physio Matters Podcast is to instigate change in clinicians to facilitate change in patients. I'm constantly promoting the fact that nothing truly adapts without challenge, so to practice what I preach, today I'm refereeing our first extended edition debate podcast with two guests with two differing opinions on the topic. The debate is 2KT or not 2KT, which, without the theatrical name, is essentially a clinical discussion around whether or not to use kinesiology tape in practice. Today's guests came to my attention when each of them published blogs on runningphysio.com. One by Rocktape UK's medical director, Paul Coker, was understandably pro-tape, but what surprised me was that it lacked the outrageous pseudoscientific claims that we've come to expect. Paul is a full-time physio alongside his work with Rocktape, working in private practice in sunny Cornwall. The second K-Tape blog was by triathlon physio, coach and athlete Paul Westwood, who put forward a strong case for minimising tape use, mainly because it's giving the general population and athletes a sense that their bodies are somehow fragile. Paul works a split role between JFT Racing, who are a triathlon team featuring some of the world's best endurance athletes, and the British Ministry of Defence. We had one Paul driving up from Cornwall, the other Paul flying in from Germany. We met at Gerard Green's Harborne physiotherapy practice in Birmingham. Many thanks to Gerard for hosting. So I was feeling brave and got them together for a chat. Two very different physios with two very different stances, but one microphone between them. The podcast team researched their little hearts out, and with the help of our two guests, a short list of literature was decided on to keep the podcast less than 3 days long. Be sure to catch the end for a discount code that gets you 40% off Rocktape and 20% off their K-Tape education courses. That is, of course, if you fancy giving it a try once you've heard the debate. So let's get to it. Welcome to the show, gents, and to our first debate podcast. I've not made it easy for myself, though, with you both being called Paul. First things first, though, let's get the introductions over with. Our listeners need to know who you are, what you do, briefly how you came to your current roles, and maybe most importantly, where you stand on today's 2KT or not 2KT debate. Starting with you then, Paul Coker.
Hi Jack, my name's Paul Coker. I'm a physiotherapist and I'm the medical director of Rocktape UK. I've been a physio since 2001 and been involved in Rocktape since 2011. I became interested in teaching some manual therapy and taping techniques after I finished my Masters in 2007 and approached Rocktape when they started in this country looking for some work as an instructor, and somehow they managed to persuade me that I should teach their courses for free and buy a share of their company.
So what would your stance be then if we've... I mean, I'm sure we can assume...
You can assume correctly that I'm pretty pro-tape. I would be. Taping is a big part of what I do in clinic. I should mention that as well as my work with Rocktape, I am still a full-time clinician in private practice, treating a general population of Joe Blogs off the street and amateur athletes. Taping is by no means all that I do as a physio. I treat with a lot of manual therapy and soft tissue techniques, really emphasise the importance of getting people moving, and I see tape as a medium to reduce pain and improve movement.
Fantastic. And over to you, Mr. Westwood.
My name is Paul Westwood, also a physiotherapist, qualified back in '98, spent a few years in the NHS before emigrating to New Zealand, where I've done most of my career there in private practice, sports academy, also occupational sports rehab. During that time, or in fact for the last 20 years, I've been involved in the endurance sport and the sport of triathlon, both as a physiotherapist, coach and athlete, competing up to Ironman level. We're even sneaking in a couple of top 10 finishes at Ironman New Zealand. Through my work in triathlon, it ended up coming back to Europe a few years ago, based in Germany, to race in Germany. Also did some physiotherapy for the Danish national squad, and that's where I also started work for the British military, the MFD. This last year I hooked up with Joel Fillion, internationally renowned Canadian coach. He has a lot of top triathletes in his team of like 10 to 14 athletes who I've been working with. So obviously I am the other side of the K-tape spectrum, the don't use K-tape, for a variety of reasons.
I'm sure we'll come to the whys and whats of this as the debate goes on. But let's start somewhere then. Kinesiology tape's risen to fame across the health and fitness sector quite rapidly in the last few years. Many patients and therapists sort of praising it as the key breakthrough product. The public and some clinicians that maybe think a little shallower than our usual listeners could say that why not use it if it helps people's pain? Mr. Westwood, by you being here, I imagine that you don't think the why not is a balanced enough stance.
No, I don't. When I first came back to the UK in particular, I would say I was a bit disappointed in the way the profession was going from what it was. I mean, when I left off, it hadn't really moved on. And it seemed to be that physiotherapy was, and I'm generalising here, but reduced the role of pain relief. Whereas in New Zealand, and again I'm generalising, it's more to do with, I can't do sport or I can't do my work, I need physio to help me back into that. When I came back, a lot of acupuncture, a lot of pain relief, and I don't think we need another form of pain relief.
Okay, are you meaning that the forms of pain relief that have existed within the profession are adequate, or are you suggesting that essentially we've tried going down that so almost analgesic route and that's failed us? Let's go at it at a different angle.
The rise in chronic pain is just getting out of control. We need to accept that pain exists in life, that it does happen, and we need to stop trying to stop pain. We accept it, and then once we accept pain, then we can move on from that. So, for example, I had a message from Hella Friedrichsen, who's one of Joel's triathletes in the United States, basically asking, Paul, are you an expert in tape? She was a week before a big Ironman race there. She was doing some exercises. She hurt herself and she said, I can't run. I need some advice on kinesio tape. What should I do? So, this was via email. She was in the States. What I did there, educated her, reassured her. I'm sure, there's nothing major going on. Try a bit of running. In the end, she didn't need the K-tape. She did the race, finished second with the best run time. Since then, she's gone on to have a really good season, doing really well. She might not have done that if she'd gone into that race K-taped up. Okay,
and so tape as perceived fragility we will start to touch on, but Mr. Coker, it's getting awfully formal with me being Misters, etc.
Yes, Mr.
Paul C. How would you counter that then? So tape's even existence makes people default to reaching for a new medicine cabinet.
I think, like many new things that come into the physiotherapy profession, some are guilty of over-promising what it can do. One of my least favourite terms is magic tape. There's nothing magic about it. It's a fairly inert product. It's just elasticated nylon and cotton threaded together. Whether physios should stop treating pain and stop trying to reduce pain, well, that's a really big question. It certainly has implications beyond just whether we should stick some tape on somebody, but whether we should apply manual therapy or even acupuncture and electrotherapy, neither of which are in my clinic, but tape is, because pain is a fallible system, and some people's pain levels are excessive to stop them being able to work and compete and enjoy their leisure activities. And tape, I see tape as a really simple, drug-free, low-risk option to temporarily reduce that pain to allow them to get moving again.
And so using it as a facilitatory tool to allow movement is where we agree on a common goal. So although there are circumstances such as the one you described where it could well have spiralled a negative consequence, can you see where Paul's coming from on that, if it facilitates movement like any other passive modality?
Yes, I can. Again, an athlete comes because they can't do their sport or because they have some pain. We as therapists need to work out why they're getting that pain, and that can be for many different reasons. If you think it's something structural, some damage, for want of a better word, then should that athlete be doing that sport? I think we can always regress an exercise or the sport to a level where they can, to a comfortable level, even if they're doing, say, isometric work. Rather than this, okay, we'll take away your pain and then push them back out into the arena. Of course, as therapists, I can still remember handing out my first cervical collar back in the day, to that whiplash patient. I felt really good about that. It gave her that instant relief. She was, oh, I love this, gave her that instant relief. We both went our separate ways, thinking we made the world a better place. But, that was 15 years ago now. And I think that kind of work that, we as physiotherapists have done has just contributed towards this massive amount of pain we see in society.
Okay, so that's an interesting point in that it would maybe give someone a reluctance to cross-train or to have an understanding of find something you can do, work around and then towards where you want to be. What would you say to that, Paul?
I mean, I'd absolutely agree, really, that in the wrong hands, used in the wrong way, then we can see that scenario where somebody's running on a forming stress fracture, for example. First thing to say is, tape's not that good. If you've got a major structural pathology, we're not going to strap you up to the point where you are pain-free and you're able to participate in impact sport. So I'm not really sure I see that kind of danger element. Certainly there is a greater danger in swallowing a bunch of painkillers and anti-inflammatories and going about a provocative activity than I think there is with tape on. But like anything, it's how you use it. And I've seen patients who are dependent and addicted and psychologically reliant on taping for activity. And just like Mr. Westwood here, I'll wean them away from that because I don't like that dependence on anything. But I think you working in private practice in this country, Jack, you must see the crack addicts. Just crack my back and I'll go about my business for another 4 weeks until it locks up again. And, we have to find a way to interrupt that cycle. But it doesn't then mean we never use manual therapy again because some people fall into that trap.
I mean, yeah, I agree with Paul. It's that kind of critical use of the tape. So, the thought process behind it. I would argue that if there's no significant structural problems which they shouldn't be training or doing their sport on, and therefore, they have some sort of pain that they need tape, I would argue then that surely use your other physio skills, that reassurance, to get them out there again, doing their sport without the tape, as I did with the example of Hella. I mean, I was in the gym a while ago, some guy came up to me, "Can you take my shoulder, please?" So I said, "Oh, why do you need tape? I don't use tape that much." And he had the look of shock on his face. "What do you mean you don't use tape? You're a physio, aren't you?" And it's that kind of, what is our role of physios, and the fact that there's guys out there thinking that our role of physios is just to put tape on and for them to crack on. So, I questions his belief and says, "Okay, again, the physio told him you've got bad posture, so you need this tape to correct that bad posture." The old voodoo mechanism of you've got that wrong, you need me to provide the cure. We went in the gym, we got him doing a few exercises, he was able to do them, allayed any fears of pain and his bad posture, and I would say that's a better result from that.
And could there be an army of tape artistes that are going out there learning this as a way of copping out of learning some more reassurance strategies using communication? You've heard our previous podcast, Paul. Pretty technical skill.
Yeah. I think we're getting stuck on tape as pain relief, and I don't just see it as a simple pain relief mechanism. I think it's more than that. It's an ability to kind of alter movement patterns, give more people greater variety within their kind of posture, and essentially reduce fear of movement to accelerate rehabilitation, which I think we all agree movement and exercise is the big long-term fix that we're after. It's just a vehicle to move us quickly along that path.
Okay, brilliant. Well, we will start to unpick and critique those other mechanisms further on. So one of the issues that we do seem to agree on, particularly off the microphone, is that we all have a dislike for the outlandish claims associated to the tape. You already mentioned, Paul C., about the nature of promising too much. So shall we first share some examples of these pet hates, firstly coming from the man in the game?
I'm not here to sort of badmouth competitors and other companies that provide education and supply tape, but I do observe them, and I think when you see a picture of a heavily pregnant lady's belly taped in a certain way with a claim that that's going to reverse a breach, I think that's plain irresponsible, and it makes my skin crawl, and kind of I understand on the basis of seeing stuff like that why so many kind of right-minded physiotherapists are put off tape as an intervention.
Because that's far end of a spectrum. Couldn't agree more. I'm sure other Paul here we don't like that. But what else is there?
I think the old bad posture stick. I mean, we teach a section on our course about kind of postural control, but really trying to emphasise the dynamic nature of it. You know, tape is often cited as that will correct your bad posture. We know from the literature that really bad posture, good posture is something plucked from the ether by physiotherapists of perhaps a decade ago. But you know, it takes a long time to kill a myth. And we're still in the process of killing that one. But yeah, so I think that's probably another one that I've got bad posture, I put tape on, now I've got good posture. I think that's erroneous.
Okay. And so, Paul, what have you encountered that's made you skin crawl?
The Rocktape brochure, for a start, with lots of semi-naked guys just rock taped up to the max, just completely covered in rock tape. Just to me, just represents this totally unrealistic kind of bizarre image that people would actually go out with that much rock tape on, and that they need that kind of rock tape, and they've got about 50 quid's worth of rock tape stuck to their body.
Okay.
Also, I think the overcomplicated nature of some of the taping strategies that I see. I think a bit of tape can work, but I mean, I remember a New Zealand athlete, she had some knee pain, and she had this most intricate, multicoloured, web-like structure around her leg and her thigh, and to me that showed that, as physios, particularly, she was one of New Zealand's best athletes, and as physios we tend to overdo things, particularly with professional athletes, because we want to try and impress them with our amazing, intricate skills. We overcomplicate things, and she could see through this as well, but obviously she just let the physio get on with it, and then put photos up on Twitter saying what the heck, and people were saying what the heck. So it's images like that, I think, that are unnecessary.
There's some theatre then, and the Rocktape company that you represent aren't immune to that theatre as well. What would you say to that?
No, we're not. I am but a small cog in a big machine. So I really look after the education and the sort of professional side of the business in the UK. I know the branding that you're talking about. You're basically looking at pictures of people with taped kind of along kind of kinetic chains and anatomy trains. I I think there's some value in that for some certain problems. It is done up for some theatre, for some advertising purposes, but at the end of the day, we are a company that crosses a border between educational and commercial, and I don't shy away from that. I think that has to be there. It's a necessary evil of the capitalist economy that we live in. I really share the pet hate of overcomplicated. I think we're known, if we're known for anything, it's the way that we simplify taping as an intervention, and really look to the research to get that idea that basically a lot of the pain relief is not that affected by the exact mechanisms of how you put tape on. There are people out there that will tell you that stretching tape 30% is fundamentally different to stretching it 40%, and if your body can somehow remember whether you stick the bit on your thigh down at the knee end first or at the hip end first, there's nonsense and overcomplicated applications are just part of the history of tape. Our mission is really to sort of demystify and to take an awful lot of that out of what we do.
Because I really appreciate the fact that you're here, and the fact that you're here tells me that you're of the opinion that you want to provoke these debates. I didn't drag you into this room. At the very least, can we say that Rocktape might be the best of a bad bunch for you?
Yes. Of course, I have to say that.
Do you?
Because Mr. Rocktape's sitting.
Well, you don't, and I know that I reckon I'm strong enough to drag you apart. But feel free to disagree with that. Yes. But could they be leading away into something different?
I haven't had that much to do with the tape companies, but certainly I totally agree with what you say. It's good that Paul has come here, represent his company, and has that critical thinking view on his product, which I think is very healthy, and that's what needs to be promoted.
I mean, we've got some boxes here of Rocktape, and the 3 key strap lines on the front of the box: treat sports injuries, yeah, okay, delay fatigue, enhance performance. So 2 out of the 3 there could be considered by a lot as being borderline outlandish. Not quite breech baby moving, but what do you reckon? Could that be better? Without being too vague, of course, could it still be marketed better than that?
Yes. I don't think that delay fatigue is that outlandish. There is a bit of research there that sort of suggests there might be some effects on that. And I think, enhanced performance, well, we'll talk about central governor model and stuff like that, but essentially our neurological system is in charge, and if we're altering input, then there is possibility and scope for that.
Okay, fair enough. We'll be coming to mechanisms of effect and stuff a little bit later on. Although we don't want to turn this into a research interpretation geek-off, which should be only littered with bias, like every other Physio Matters podcast, we can't ignore the evidence. We agreed on a short list of articles that were worth discussing briefly, and so starting with using tape as pain relief and moving on to other areas, what do you feel that the evidence suggests, starting with you, Paul W?
After reviewing extensive amounts of papers on tape, washing my brain with tape, fundamentally the research is scant. The recent research, the Brazilian one, what was it called?
Pereira,
yeah.
Probably mispronounced, but yeah.
I mean, sum it up, saying taping doesn't have any benefit over sham placebo taping, and the benefit was too small to be clinically worthwhile. Therefore, current evidence does not support the use of kinesiotaping for musculoskeletal conditions, which, after going through all the literature, sums up. There is some small efficacy, small amounts of effects that can prove beneficial, but overall it seems quite shallow.
It doesn't stand up to the science as of yet. Paul Coker, what do you reckon?
It doesn't stand up to systematic review at this stage. Systematic reviews are always going to be contentious, and we can read them in different ways, essentially. The Pereira study does include, I think, 4 papers where the authors felt the results they got were significant, and the reviewer then kind of essentially dismisses those changes as not clinically worthwhile. When the studies are involving small n numbers and are low quality, then I think that the question has to remain open to bigger and better studies as to whether the effects that those things are picking up might actually be greater. There was another systematic review done only last year by Calron, and part of their conclusions, although they're, again agreeing that the research base is not fantastic, they did feel there was moderate evidence for pain relief. I don't know that there are that many things physiotherapists do other than prescribe exercise and movement that stand up even as well as that to systematic review. I hear the statement very often, there is no evidence for kinesiology taping. I don't think that's the case. I think the evidence could be better, but I think there's some really encouraging results from some half-decent RCTs starting to come through.
So, the word, it's a pet hate of mine, is the word proof, and I'm getting a bit bored of people suggesting that things have been disproven in science. That's certainly not how I understand science, so I agree with you there. Where would you say you think that the research is of its strongest with kinesiotape? What area?
I think pain relief, because of the nature of the studies that have been done. A lot of the papers held up essentially by naysayers are studying healthy individuals, and if we're got no pain, no limitation of movement, no fatigue involved in the study, I don't think it's that surprising when the tape comes back with no effect. So I think that as a clinician, I'm always way more interested in reading studies that are actually about people that have got a problem, have got a pain, and whether the tape has effect on that. And we can pick out a couple and talk about them if you like, where the results are pretty encouraging.
Well, we'll certainly, we're going to come to those in a second because we've all had a chance to have a little read of them. But if we were to say, and again, myself having fried my brain over this kinesiology tape research, we would sort of see it quite easy to deconstruct it. My main thing is that it's seemingly hard to get an appropriate sham group, which is one of the reasons why I think people call it out as being simply placebo effects on positive results. So it does make you think, is that limiting the potential effects of what tape could show as being useful, or is that just the devil in the detail? Does it not matter? What would you say, Paul W?
To a point, is the devil in the detail. There was the study done on the gluteus maximus firing. That was quite an interesting study because that did show that there was improvement over a sham group, but then they didn't use a control, so they didn't use a non-sham or non-kinesiotape group. So it could be just down to learning that they improved.
How would you construct one? It's difficult. None of us here have a specific research role at present, but if you were to sort of construct one, do you think that's doable? Do you think there's a way in which we can, as an audience, try to direct people that are doing research to make it more robust at least?
Well, as Paul says, it needs to be done with people in pain, if that's what seems to be the overlying factor, that a lot of these weren't done on people with pain. And again, that has its limitations in trying to find that study that works like that. Is it because they're getting that attention? Is that why they're getting the relief from pain? Very difficult.
When it comes to MSK pathologies, if we're all in agreement that let's test on people in pain, how can we make a more robust sham group, and how could we blind appropriately, and why is that not being done already?
I guess the nature of my work, I read a wider group of studies. I think there are some reasonable attempts being made, and I think there are some different options. One is essentially the same procedure but using a different medium. So micropore and silk tape have been used in a couple of trials instead of a kinesiology tape.
What are these promising RCTs then?
So let's go back to that buttock study that you mentioned. I am a fan of buttocks. Basically, there was a tape application which was done according to the methodology of Kenzo Kase, where essentially the tape sketches the outline of the glute max muscle put on in a certain position with a certain amount of tension. And then there was a sham taping in inverted commas group where two strips were horizontally placed on the glute max muscle. and both groups showed changes in their, I think it was jump height, is that right?
Yeah.
That they were investigating. What this really highlights is how little we really understand about how tape interacts with the body, and that we don't have a gold standard of clinical application methods. We've got loads to learn, and if all we investigate is one methodology and one application type versus nothing, or a different substrate of a silk tape or a micropore, then we're really limiting our scope for investigation. We almost need to go back to the drawing board and say, right, stick some tape on skin. What does that do to muscle strength? What happens if we change the amount of stretch? What does it do to pain when we alter various factors about tissue and tape stretch as we apply it? So I think there's kind of methodological issues around that. One of the best shams, really, that sort of it does matter sometimes how you put it on. So we get to this: does it matter how you put the tape on? The answer is it depends. Sometimes it doesn't, like in that glute max study. Sometimes it does. So there's a study by Anand Kumar that came out this year that was essentially looking at the effect of tape on isokinetic quads torque and stair climbing in people with knee OA. They had two groups. One got taping that was put on with some stretch on the tape. One group got no stretch put on their tape, and only the group with stretch tape showed changes in their isokinetic strength, the time it took them to climb the stairs, and the pain that they had while they were doing that. So there's indication there that if it's just placebo, then it shouldn't matter at all how we put it on, and in this case it did matter how the tape was applied.
Certainly an interesting study, and one I wasn't aware of before, so thanks for putting it on the list. Before I pipe up, though, any thoughts on that, Paul?
Yeah, interesting study, and take on board everything you say. One thing I would say that there were no long-term outcome measures measured after that. So, will you just get regression to the mean afterwards, and will things just turn back to normal after that tape's been applied? A few weeks, a few months down the line, will things be status quo again?
Yeah, longer term follow-up, a tough one, and a shame it's not. Looking at that one, certainly a better placebo, but we've all worn tape, I assume. Sorry if I'm looking at Paul W here. Have you ever?
Every day, I can't.
Suddenly a big revelation. So if we've all worn it, and you can feel it, I'd argue you can feel it more when it's stretched. Therefore, again, in that study, why would it improve quads torque? Could it be that the more stretch, the more sensory feedback? We're going to come on to mechanisms of effect, but again, one of the better studies, and interestingly, again, it's showing something that a variable more than just pain, but why could it confound the results?
I think that, because the two groups basically responded very differently, and as you say, one group's got no stretch and one group does have stretch on their tape, that fundamentally what we are looking at when stuff changes because of tape is sensory input. That's what we put right at the top. What's tape for? It's for altering sensory input. Quite how that leads to sometimes fairly dramatic increases in muscle torque, that's a question for people way cleverer than me, Jack. But I can observe it, and I see it in clinic. Literally every day make a big difference to somebody's weakness or inhibition that they're seeing. So it's a great facet of tape, is this sort of increase in muscle activation that we seem to see as a result of it. But mechanisms, I'm not that smart.
We're certainly going to dabble with trying. Paul W., you work with some of the world's best performers, and so if there was going to be suggestion that K-tape was going to improve someone's torque, at least on a training field, or at least in the gym when you're working with the S&C coaches of these top level athletes, you still feel that the negatives outweigh the positives?
Yeah, definitely. I mean, I think that increase in torque for me, possibly could be applied to more acute injuries when you have got like not so much muscle activation. But for a fully fit athlete, how much increasing torque can that be? The amount of torque that a quad muscle can produce is a lot more than is actually being produced. So what is producing that torque is a lot more complicated. Okay, there's a whole heap of factors going on there. I mean, physiological things going on with the muscle strength, psychological things about how much that athlete is in tune with their body and their hopes, desires, all that kind of thing. Sticking a bit of tape on that muscle and maybe increasing it a little bit in a clinical setting, I think it has minimal value. And then what risks do you run then of the muscle will always adapt into what situation you put into it. So will the muscle then just become weaker and adapt to the muscle, to the tape that's been put on it? So like putting a support on an athlete and then go and tell them to go and run, they will adapt into the mold that you give them, which will be a weaker, underperforming one compared to that mold that you give someone to just go out there and train their body.
If we were to say then that even if this research was incredibly robust and it had improved quads torque, at a clinical level, we could even say so what to that. And I know that goes broader than tape, doesn't it? But improved quads torque, will that improve my ability to do my job? Maybe not. Would you say in your clinical practice you feel like that gives you an opportunity to do more?
Indulge me in telling you a story, like just literally from this week.
Cool.
Old patient of mine walks in. I've seen him a couple of years ago for chronic low back pain. Told him it's been driven by his horrendously arthritic knee. He'd finally succumbed and gone and had a knee replacement. Really struggling afterwards. So we're sitting on the bed. We're trying to get a straight leg raise going. Can't do it at all. So stacking him up, trying to just do an open chain, inner range quads, not that inner range because of the amount of lag that he's getting. And I'm kind of fiddling here, poking there, trying to give him some input to change it. Nothing's really working. So I tape his quads and his lag literally halves in a second. He gets up the bed and he walks across the gym better than he's walked since his operation 8 weeks ago. To that guy it matters, and his function is going to be better temporarily. I do think we drift back towards the mean when we take tape off again, but he's now able to perform his exercises and to walk with way more confidence and way more ability than he was without it. So it's always back to that thing of, like, in the clinical setting, sometimes relatively marginal short-term gains can be really clinically significant.
I mean, with athletes, I'm wanting them to reach above where they are at the moment. Long-term benefits, that's what I'm, long-term performance, long-term, being the best they can be. And I want them to do that intrinsically without having any sort of extrinsic support. They need to learn how to do that for themselves with the support and guidance of coach, physio, strength and conditioning coach. But they need that strength to come from within, not from put this tape on and get that muscle working.
So time is going to play a part in all of these things, but you've got extensive experience working with jaw blocks, with someone that's had a knee replacement. Where would you say you'd stand on not necessarily having to counter, because as I say, we weren't there, we can't counter directly, that would just be rude, but fundamentally, where would you say that the key drivers of an influence might be had in that sort of circumstance? So
there are instances like that where tape does seem to help and have these, really good, almost miraculous results. It does happen. The methods and the reason for that, I would argue mainly due to central nervous system rather than anything physiologically going on with the muscles and the beliefs, thoughts of the patient that works on, pain modulation and etc. The people I tend to see that does work on, to counter with an anecdote over myself, I saw a guy just before coming down here who was, I said I was coming to discuss K-tape. Oh yeah, I had that done. I had calf pain for 4 weeks. I went to see this guy. He put some tape on. It was awesome. Worked for 3 days, and I I was fine then, the pain had gone away. I would say for him it's mainly working on his, for want of a better word, on his brain, the attention he got from that guy, rather than anything particularly going on at anatomical, structural level. He was also a guy then, because he said then, I don't know whether it's placebo or what's going on, pointed to his wrist and he had one of these magnet things. I don't know whether this is placebo, but when I first wore it, it made me sleep better. He's into his supplements and, various different things. He, in my experience, tends to help those kind of people. There seems to be a certain type of person that tape helps. I know other guys, the physio put tape on me, I didn't really want them to do it, but I didn't want to let the physio down, so to speak. They were putting it on, so I said, that feels really good, just to get out of the physio room, and then as soon as I got out there, I took it off. They're those guys who just won't buy into the K-tape.
Okay, so brain influence and all, and Paul, see, it is novel, isn't it? It has got that value. In that circumstance, you were poking and prodding, and the attention you were giving to him didn't change with the tape. But to introduce a novel product will confound the outcome to some degree, will it?
Yeah, I think in the real world of clinical practice, it's utterly impossible to separate out a placebo effect from attention and from care. From any kind of physiological and neurological interaction that we're causing. I don't find that pattern where a character type of the kind of tree-hugging, magnet-wearing, supplement-taking person is the only one it works on. I live in Cornwall. I treat like farmers and fishermen with stuffed rotator cuffs, and you stick some tape on and they grumble at you.
Cornwall's full of hippies.
Maybe that's what it is. All I treat is hippies. The whole thing's falling apart. No, but like these guys, and they've got no awareness of tape at all. Like they don't know it from anything else that we do. And you say, just stick this on, see how you sleep tonight, And not even that. I try and avoid telling them what I expect the tape to do, because I don't want to set up that expectation. I genuinely am interested in every individual's response. And I do see people turn around that they are massively skeptical that this is going to do anything, and then they notice effects. Those effects are sometimes instant in terms of improved range of motion or muscle activation. They're sometimes more kind of gradual things about getting a better night's sleep, and of course it's hard to pair that out from everything else that we do. We give reassurance that there's nothing serious going on, that their arm's not going to drop off, they're not going to keel over dead tomorrow. We've given them an exercise program as well, and so in the clinical setting, tape comes as part of a cluster. So it's always going to be hard to par out its individual isolated effects in that sense.
And my questions are often directed this way, and I've even blogged on it. So it's little secret that my favourite topic is to discuss the mechanism of effect behind interventions. So if we expand on what we've already touched on, based on your experience and a degree of biological feasibility, how do you personally think that K-tape works?
3 things. I think there's some direct pain relief through kind of counter stimulation, essentially kind of operating a pain gate type mechanism. Mm-hmm. I think that there is a decompressive effect of tape acting on essentially on skin versus the sort of superficial fascial layers, and I think it's plausible that might be actually directly taking pressure off pressure sensitive nerve endings, so a kind of stopping nerve endings reaching action potential essentially. It's not that unreasonable though, although I think it's been overplayed historically that the tape has a fluid effect on lymphatic and blood supply. Research around that is next to none. So I don't really kind of put that really high up the list. And then it's a diffuse and to an extent non-specific neurosensory stimulus. You're increasing the variety of input from the taped area to the rest of the nervous system, both peripheral and sensor. central. I think that system is so complicated that I am pessimistic in a way about our ability to identify the exact channel and mechanism by which it's working. The way I explain a lot of what I do as a physio to patients is essentially like, and younger listeners will have to forgive me, but pre-flat screen TVs were thick and fat and had diodes and stuff in the back, and if the reception got bad, knock the side of the box and the reception gets better. We know where to hit and we know what the outcome is, that the picture gets better, but we fail to appreciate and understand what moved and reconnected, changed within the back of that telly. And I see what physios do is a lot like that. We know some places to knock and we can observe some outcomes from it, but the exact specifics and intricacies of that mechanism of effect within the neural system, I'm not sure we'll ever really get there.
But should we keep trying?
Maybe. I think we have bigger fish to fry in the tape research world than necessarily that side of investigation.
Mm-hmm. Okay, and what do you think to that then, in terms of its the feasibility of what Paul's suggesting or how the tape works?
I mean, they all valid points, and yeah, I mean, I wouldn't go against any of those kind of effects at all. Essentially, are you just itching the itch, as it were? And maybe that's what tape has. But I think we do have bigger fish to fry. I mean, I think as physios, we shouldn't be spending all this time on, a product that maybe helps to relieve a bit of pain. But I think physiotherapy has a lot more to offer to people, to sports teams, to communities than putting on a bit of tape and helping hurty knees.
So if it's interacting with the nervous system as Paul C promotes, then you think there's bigger fish to fry in the way in which we can influence the nervous system for a positive effect?
Yes, definitely. Yeah. More prolonged, more longer term effects. Okay, so if someone comes in with you with their hurty knee, rather than just, okay, I'm going to take away your pain, let's see what we can do in your life, let's get to know the person, give them something to, make that person, improve that person, rather than just taking away that pain.
And in that circumstance, when, say, Paul's taping, okay, and say, we can even broaden it, in his intro he explained use manual therapy, soft tissue techniques, and then lead to promote movement, which is the only way we could ever say on this podcast that we would instigate those things. When he's doing that, what are you doing? So,
finding out about the person, good subjective, finding out about their history, them as a person, how they behave in the world, their belief systems on the world, allaying their fears. They come in with a painful knee, so they obviously think there's something wrong with them. I've got arthritis, the classic stories. The GP said it's only going to get worse, that kind of thing. You allay all those fears, and ultimately then you will have, you will start having benefits. Show them what they can do. You can use manual therapy in that instance to show that I'm not against manual therapy. Move that knee, get it moving, see that their knee can move. Interact with you as a therapist, your one nervous system, they have their nervous system, and it's those two nervous systems interacting and giving a positive long-term effect for the patient.
And so so proposing that the time taken to scratch itches, eats into the stuff that really adds value to a consultation. Do you feel it compromises your ability to do that?
I'm going to say no, Jack, but there's
time limits, isn't there?
So there are, absolutely.
Something's got to give.
An awful lot of people out there are working on 30-minute appointments, and we'd all wish we could spend longer with our patients to dig really deep. But I'm not saying that I don't do any of those things as well. Again, it's back to this thing. It's not just about pain relief. For me, tape can be a really powerful reminder as people leave the clinic, if we've sort of advised them and instructed instructed them to do things in a slightly different way. So like a good example is like crossover gait, somebody's got ITB pain and you observe that they've got this kind of crossover gait and you think that might be contributing to it. The kinesthetic nature of tape can work as a really kind of positive, non-provocative reminder and sort of stack the deck in favour of the patient making the choice you're after rather than the choice they were making previously. So I see tape as this kind of extended touch, essentially, get back to that idea of one nervous system interacting with another. Diane Jacobs will call it social grooming. Well, tape is, in a sense, kind of my fingers and my words left on the patient after they leave that relatively short 30-40 minute session in a week.
I think what I would prefer is they go away without me touching them. They go away and they function and have faith in their body can function. For me, it would be another reminder that they are injured or they do have
Okay, a crutch.
Yeah, a crutch and an indication to the outside world that, hey, I've got a problem, so there you have the benefits of pain and you have the benefits of an injury and an illness and the way that they get beneficial things from society because of that. They get attention, they get sympathy, all those kind of things.
I needn't even summarise that, do I? What do you reckon? Tape as a crutch? Why else would it be brightly coloured, Paul?
Yeah, some people show it off, some people deliberately hide it. Why does tape come in lots of colours? So that people can have a choice in what they wear, because we are asking them to usually keep this on from between sort of 2 and 7 days. And so I think that's the main driver to variety. It's not proof of some kind of evil commercial empire. It's just about giving people a choice. If it's a crutch, it's a really light one. And sometimes that legitimization of somebody's pain, which is essentially an invisible limitation to their life, their capacity, to an extent, short-term validation of that can be helpful for some people in some instances. But this idea that all we do is stick tape on people who dress up in lycra at the weekend and they wear even less lycra so that they can show off their tape, that's one very thin slice of the treatment pie.
And that's a fair point, is that as far as adjuncts go, and I won't rant on about adjuncts as I often do on Twitter, for example, but it's a pretty brief one, and it's also one that then does have some, you could argue, some more lasting effects during then after a treatment session. So of the passive interventions, pretty quick. If, say, it was played down, well, why could that be problematic? Would that still perceive fragility on everyone?
I would argue that, or what I would be thinking about is, like, why take the risk? It does depend on the client, and obviously subjectively knowing the client, knowing their beliefs, you would come to the decision then on what adjunct you use. For most athletes, most people out there in fairly robust roles, or need to be robust roles where they need to be more than robust, anti-fragile, I think you take the risk then of them becoming dependent on that. And why take the risk when, as a physio, I know they will get better, they will get back to doing their sport, because the body does heal itself with the right management strategy. You do your exercises, your strength, and you will get better. So why take the risk in introducing this potential crutch or potential insecurity or potential excuse? The guys I see lining up at races with their K-tape on, I see guys who have already got their excuses. They could hold, might as well write it on the sign. This is my excuse for failing today. And, once you enter the arena, and, this applies to high performance athletes, recreational runners, whatever the level, you're going to your local 10K race, your unconscious, subconscious mind will be looking for that excuse. It will be looking for that get out clause. It will be looking for that reason of not doing a PB today. And I think kinesio tape, that crutch, provides them with with a reason. I mean, going back to pet hates, one of my pet hates, which I see on Twitter, on Facebook, social media, is the hashtag held together with tape. How is that healthy for an athlete to perform in life, do anything, when they perceived condition of themselves is their body is held together with tape? But the body isn't held together with tape. Their body is coping fine, which is not a healthy strategy. It might, for that time, get them through a race or get them through something, but then in New Zealand there was a kids day on, and half the kids had tape on. And what is it, a message that we're teaching our kids, where you can't go out and do sport, you can't go out and run around unless you put this tape on. We have to have faith in our bodies being able to perform, because our bodies can perform a lot more than they are doing at the moment. We'll probably talk on performance, but we're only going to get faster and quicker and stronger as human beings. That isn't because of tape.
Okay, and that's one of the things really, Paul, about you proposing that two of your three things that you mentioned as to your proposed mechanisms of effect of the tape are mechanistic to some degree. The tape is somehow, albeit on a low level, mechanically influencing the body. If people catch wind of that, and I can understand how you land on those things, but if people catch wind of that, is it just going to give them even a subconscious sense that they need it?
I think it's all about the delivery and the pitch that comes with it. I think that we can see fragility from exercise. So I get people who come in and they tell me their glute med doesn't work. And you think, well, that's amazing because you're standing up. Clearly it does. But the way that exercise has been sold to them and their diagnosis of inhibition underactivity in that area has been dramatized, has led to a fragile brain on that person. And so I get the argument. I just don't think it's very specific to tape. I think it's specific to everything we do in terms of intervention.
But we don't see hashtag held together with Pilates. You could say that a more passive, particularly a more glamorous intervention is going to provoke those sorts of things. There's a photo that can come with it. There's the way in which that can be then promoted.
I think physios have to get away from feeling the need to intervene all the time. They have to do something. We need to have the faith in our profession and our skills, education and exercise, working with that person, that they will be the ultimate way and that person is going to improve. Physios for some reason always feel like they need to intervene, even though they get all those things. They just can't help themselves. We'll just do some acupuncture, or we'll just put some tape on as well. I'm here because I went on one of Tom Goon's course, running with pairs. He won't mind the plug, and he was there talking about his knee injury at the time. I think he's had a fair few injuries, and he was saying all the right things. Yeah, it's getting better and improving. I'm doing this, I'm doing that. Then he lifted up his leg to expose the tape, and there it was. And he kind of knew he didn't need it, but at the same time, he just couldn't help himself. He felt like he was like sucking a dummy, as it were. He couldn't get away from that.
Do everything you can. Throw the kitchen sink at it.
But I think just to come on that idea of like the athlete standing on the start line, taped. And it's this sign up saying I'm going to fail, basically, or if I fail, this is why I'm going to fail. The flip side of that, and the way that a lot of athletes that I work with see it, is it's their weakness taken care of to an extent. So like my world's ultra running, and inevitably wherever you are in the pack, front, middle or back, most people at the end of the race slow down dramatically because of focal fatigue in one muscle group or pain in certain areas. And whatever strength of physiological effect there is with that tape, sometimes there's a massive increase in mental robustness in just knowing that they've done something about that they've taken care of it. And again, it comes down to that thing of how you sell what you're doing. I dislike that the tape holding me together, magic tape hashtag, just as much as you do, Paul, but I think it's about how you sell the intervention.
Two endurance athlete physios, we've one of the things you threw into the mix was Noakes' central governor theory. There's got to be a good reason for that. Of course, we can second guess it. But would you like to sort of see how you feel that tape influences our understanding of fatigue then in that sense?
Professor Tim Noakes developed the central governor theory of fatigue, which went against normal methods, the catastrophization methods where we stop running or we can't go as fast because our muscles fill up with lactic acid and they stop working, which was a brainless model. So muscles just couldn't produce, just work too hard, produce lactic acid, and then we had to stop. So he said, no, it's the brain that decides how fast you go, how far you go. So at the start of a marathon, your brain is already determining how fast that you will do that marathon based on things that happened in the past, the training that's gone on, based on how they've done in other marathons, based on how hot it is on that day, and therefore how the athlete perceives it will work in hot or cold conditions. So more multifactorial response to fatigue. You'll start running then the brain's totally working on measuring the environment, so also measuring how much force is going through the muscles in the leg, how much glucose is in the blood, the level of oxidation, whether their mate's catching them up, whether that arch rival is up ahead, whole heap of inputs going into the brain, and then that brain is making the unconscious and conscious decision on how fast it wants to go. Because the theory is that the body is capable of a lot more. Noakes says he knows that someone could have gone farther or faster if they get to the finish line and they're not dead. Because the brain is causing limitation or limiting the body in order to prevent failure. So either that be muscle damage or cardiac failure. The selfish brain always looks after itself. Mm-hmm. So that brain can have no excuses for ultimate performance. Say an elite athlete can use 80% of its muscular ability. He cannot have any excuse. If he does have any excuse, such as wearing tape, then he won't use that 80%. And tape can't add much to that 80%, or can't make that performance any better. There's too many things going on, too many bigger picture things going on, which will enable him to reach that step further and win the race. Tape isn't going to do that. What is going to do that is the belief in himself that he is the ultimate performer and that he can win anything and beat anyone. And the athlete that does that is the one that doesn't rely on tape.
So there's more, again, it's that thing of there being more important variables than sensory feedback. Paul?
Yeah, there probably are more important variables in terms of endurance sport performance. Training, nutrition, hydration, preparation, sleep. All those kind of things are going to make a bigger difference than whether or not you've got a piece of tape on your quads. But I think that what the kind of central governor model really kind of highlights is essentially the number of variabilities there are to the input of fatigue, and tape sort of sitting on your largest sensory organ right over the muscles which are acting as your engines to that performance might plausibly, possibly give us an extra couple of % here and there. I talk to elite level performers who absolutely swear by it. Whether that effect is in their skin, peripheral nervous system, or in their higher cognitive centers, they're not that interested. They feel like they go faster for longer with tape on. And when it comes to fatigue, I guess I feel like if I wear tape, it makes a difference, and I would challenge listeners who are skeptical about the benefits to go and do a hill repeat session one day with no tape on their quads, and then go back a few days later once they've recovered and try it with 2 really simple strips of tape up quads. I feel like it makes a difference when I do it. I don't think it matters exactly how you put tape on in that instance, so it's a nice little experiment to run, and people can draw their own conclusions about the effects of tape on fatigue there.
But then aren't you only just conditioning the brain then, when I run up hills, I need this tape?
Such a tough one. This is why it's such an interesting debate that could go on, and we're certainly not going around in circles at all, gents. There's new fresh stuff coming to the fore. What I'd say there, Paul, is, are we belittling our role somewhat then? If we're just going to be trying to, it's doing something, it doesn't necessarily matter why, the mechanism of effect is so difficult to measure, could we be doing the important stuff that we've all agreed with? I know that's what we said about promoting exercise, promoting movement, educating, reassuring, making sure they're not thinking it's a crutch. And if they get that, and we think we're going to tape them, then it could be our local masseuse, it could be our physio assistants, it could be our siblings that are lawyers. We could get the patient to do it themselves. Are we belittling our role to be that itch scratcher?
I don't think we are. And I'm giving like another general example. It's not a specific anecdote, but there's a way that you can put tape on a leg, which in some instances will sort of give people quite instantaneous changes to their squat pattern. And reduce sort of essentially triple flexion failure, so internal rotation of the hip, medial drift of the knee, and early and prolonged pronation of the foot. Now, if you put a bit of tape on a runner that does that, and their niggly proximal hamstring or Achilles tendon is better whilst they are running with that tape on, the way I explain that when they come back in and go, boom, that was better, is say, okay, if you do your rehab, you can be like that all the time. And so it's a buy-in. It's a way to give people a glimpse of what it would be like if they could strengthen here and change a movement pattern there. So I don't think it does belittle us at all. I think it can really help to back up what we are saying. But the problem, and we all know this as physios with exercise, is compliance, because it takes time for people to see changes. So if you can give them a little flash shot, then I think that's really positive, and it really helps with compliance.
But if I was to say to one of my physio assistants that this patient would benefit from technique C that I showed you last week, do you feel that their application would be any less than mine?
Sometimes. It's such a boring
because
exercise.
we've got a better rapport.
Yeah, and I think experience kind of gets you a better understanding of when to try and change a lot and when to try and change a little. And it's about a package of advice and education and exercise prescription and those other things. Everyone can go and read Adam Meakin's blog on is there any skill in manual therapy, and you could apply the same thing to tape and just make it this recipe style. And there are education companies out there that teach tape in a recipe style way. We really try and stay away from that and just teach concepts and give people the clinical freedom and tools in which to decide, and make it a fully kind of customizable tool for rehab, rather than just saying it's application A, B or C. You say, well, it depends on the individual in front of you. And look, don't get me wrong as some kind of evangelist of tape. Not everybody who walks into my clinic gets tape. There are times when I don't think it's appropriate and I don't use it. It's just another tool in the box, but I think it's a really valuable tool, and it's certainly one that I come to commonly.
And I don't think it's going to necessarily be specifically about that obligation to intervene that we have covered a little bit, Paul. But what do you have any thoughts on that in terms of its does it belittle our role?
I agree with what Paul's saying there. There is a place for us to intervene. I think in the real world, though, I think we intervene far too much, and often what I see is physiotherapy treatment is driven by the intervention that they want to do. I mean, you can say it with taping courses, everyone goes on a taping course, and then next week in clinic, everyone's got tape on them. And all of a sudden that's the way to cure people and make people better. And then, and then it goes back to the voodoo that physios do sometimes. You've got this wrong with you, you've got that wrong with you, you've got flat feet, you've got scoliosis, you've got an upslip of the pelvis. They're creating the problem for them to apply the intervention.
But would you, that agreement there with when to intervene brings me on to my next question quite nicely. I'll put it straight back to you. Is if there's a place for tape, where is that place? And where isn't that place? So I'll pose a few things. Training, rehab, performance, swelling, endurance. Where do we see it as being most feasible if we're going to not promote it, but suggest that that's more realistic?
Obviously, I think the use of tape is minimal. I've already said my views on the use of tape. Where I would possibly use it, you do, as Paul said, you do get those people. Sometimes you've just tried everything and you think maybe tape might work. Give it a go in that situation. But I would have to, screen the patient almost to check that there weren't going to be any detrimental effects on them. For most high performance athletes, I would say they shouldn't be using tape, because that would, most athletes I would screen, they shouldn't use it because it is that slippery slope.
And do you mean in performance, or do you mean full stop?
I mean full stop.
Yeah.
Potentially, they were an athlete who had used tape in the past. Fair enough, I did have an athlete who did use tape in the past. She had a long history of injuries. At first I didn't tell her to stop using tape. She continued to use it. I was okay with it, but I approached her in different ways and encouraging that, her body's not going to break and that she can return to the runner that she once was. Eventually she did buy into all that, and she did become, and is now becoming, the runner that she once was, and has drastically reduced the amount of tape. So that's when, when I am going to use the intervention of tape, is there going to be any detrimental effects? If I can screen someone and say, okay, no harm in using some tape to enable them, again, not necessarily to take away pain, but to enable them to then perform a movement, a function, sport or work.
Okay, and so that's interesting that last gasp is something that you'd consider. When specifically would you say not to? Is there any particular things that are bugbears where you think that is exactly when not to? So I don't know, acute injury, swollen knee, that sort of thing.
I think you see the pictures up on. You see the pictures of when tape is used for a swollen knee, for example, and you see that strain, the basket weave kind of effect of the bruising for a very swollen knee, possibly. For me, maybe a tubic grip does the same thing. Again, I think the basket weave is a good marketing strategy. I'd like to ask Paul. Obviously, you see the basket weave, and there's areas where there's no bruising. That's all good. So there is the areas where there is bruising a problem.
So anybody who's been fortunate or unfortunate enough, whichever way you look at it, to have sat through a FMT course with me will know I stick the slide up and pose that exact question. So we can see a bruise has cleared where tape has been, so the fingers of the tape, the bruise is cleared, and where the tape hasn't been, the bruise remains. I think the first thing that those pictures show, and we can bang one up on them for the listeners to have a look at, is a clear interaction between the body's physiology and the tape. But the very obvious question is, well, if you just covered the whole bruise in tape, would there now be no bruise as opposed to just little bits of bruise? And the honest answer is I don't know what the answer is for that. Basket weaving around swollen areas is an interesting one. There is very, very little research or very little proof of any kind of a unique mechanism to that taping approach. I'd say it works in about sort of 50 to 2/3 of the 50% to 2/3 of the times that I put it on people. I don't think it's massively reliable, and I think it's just different from compression, and sometimes compression works. There's essentially two hypotheses behind why we do that. One is this idea that we create areas of high and low pressure, and that creates some kind of mystical microcirculation within the body. Sounds highly fanciful and not that plausible to me. The other story behind where that tape application comes from is essentially that in the very early days of tape, it cost people a lot of money. So when they saw a large area of problem, they took a very small amount of tape and spread it as widely as they could over that area. But it does seem to work in a slightly different way to reduce swelling where solid strips of tape don't. So I think what happens to a bruise and what happens to an effusion aren't necessarily the same things.
I think performance-wise is an area I think where tape doesn't have a place. I think performance, improvements in athletic performance, tape isn't going to provide that improvement. You always see it in various products, supplements. This will improve your performance by 1%. Some clothing, this will improve your performance by another percent. If you add all those percentages up, then your average recreational runner would be making world records. Essentially, though, those things don't add up to, the whole thing like, the difference between the guy who won and the guy who's second is, half a second, 1%. So if we can use this product which improves by 1%, then we've won. Mm-hmm. Yeah. It doesn't look at the broad picture of what sport performance is about. Mm-hmm. Essentially, good training, good technology, and the belief.
Yeah, and Paul Coker then, if I was to give you, hilarious that I'd be giving you tape, but if I was to give you a roll of tape and said, ration yourself, I'm sure there's some listeners that love the idea that you'd use that within an hour, but if I was to say use that's your week's worth, and you've got a full clinic, you've got 15 patients a day, what would you prioritise that role on then? Where's the key intervention when it comes to tape?
That's a good question, Jack. I don't like having to ration myself with things that I like. My solution to the problem was to buy shares in a tape company. I wouldn't recommend it to everyone. I guess in my clinical week, the people I would save that roll of tape for would be acute low back pain, sort of muscular spasm and local dysfunction, as opposed to sort of radiating and radicular symptoms. That I often see that application of tape in those cases make big instant differences to people's overall pain state, their available range of motion, their perceived kind of fear of the situation. We talked about tape being a crutch, and in that sort of situation you perhaps tape up whatever you think is appropriate, but it might be QL, erector spinae, or just a kind of diagonal X across the thoracolumbar fascia. When that starts to make an instant difference to pain, the kind of message I try and give with it is sort of, see, there was never that much wrong. If all it takes to unwind that pain state is that, then you can be reassured that there's nothing significant going on underneath. So yeah, I think those people who walk in barely able to move in any direction, I'd save it for them, because I'd have the most confidence that that's where I was going to see some good results.
Probably the most fear avoidant group that you would then land on, and that's what's interesting. Any thoughts on that, Paul? First and foremost, did that surprise you?
No, because people who use tape, that would be the go-to thing, and that is my argument. It shouldn't be the go-to thing.
Let's play same patient, different clinic. You don't have rations, and I'm not going to start being dictating what you'd use. Well, how would you manage that situation differently? I mean, we've covered some of the educational reassurance strategies and stuff. That's a sort of circumstance, particularly if it was first onset, that there is an indication for an adjunctive method to try and help someone in the short term to get moving. What would be your go-to thing, if not K-tape?
I mean, my go-to thing would be to get that guy in the gym, for example, and start to see moving, encourage that movement. if I was going to use an adjunct, then I would use hands-on as the go-to thing, and getting moving, mobilisation with movement, for example. So then he goes out of the clinic, walking and moving better, without taking any of that adjunct with him.
Yeah, find something that he can do. And do you think, Paul Coker, that tape is manual therapy, isn't it?
I guess you have to lump it with those things. I'd rather it got lumped with manual therapy than it sometimes gets lumped with sort of the more weird and the wonderful, and sort of cited as a sort of form of, to quote Paul Westwood here, physio voodoo, where physios definitely have a tendency towards that. And I just don't see tape in that weird and wonderful bracket. I think it's quite a sensible thing to do, to try and interact with somebody's nervous system in a way that lasts and reduces threat.
Yeah. Do we agree then, as the three of us, that from what we understand of pain, all three of us an interest in that, there's no reason why it wouldn't help to neuromodulate pain? Would we agree on that?
Well, I would, but that's easy.
Yeah.
Yes, it can be an adjunct.
Yeah. Yeah.
Possibly.
Yeah. Just picking your patient. Go on, sorry.
I think one of the issues we have with tape, going back to whether I would use it or not, and it maybe does have a limited application, with the massive rise in tape companies that are out there making money, which is nothing wrong with making money, surely the market is flooded, and surely unless we do see extensive use of tape, the pictures that in the Rocktape manual that show extensive use, if we're just limited to just putting on a bit of tape now and then, which I would agree with, that's not going to satisfy the market. So therefore, the market does have to push tape on people.
Like, I think people often see those pictures and think we're using a ton of tape, but other people will tell you to sort of pile tape 5 layers deep, where all you're doing is taping more tape. I think actually sort of taping along fascial lines can have a really positive effect if you pick your patients right. I assure you, it's not driven by a desire to sell more tape. Ultimately, that's quite an insignificant change between somebody using 40 centimetres and somebody using 80 centimetres of tape on any individual patient. There are lots of companies now who produce a roll of kinesiology tape, and it's no great secret that most of them come out of one or two factories, and they just shove it in different boxes. There's lots of cheap and nasty tape on the market. It won't stay where you put it, and it'll irritate your patient's skin. We really are, we have tape at the heart of our company and movement at the heart of our company, and we really want to raise the standard of both the product and the education and understanding that it has, because I think it is a misunderstood intervention as a result of its history kind of coming out of Far East countries and getting tied in with colour therapy and applied kinesiology and acupuncture. And I don't think it should be seen like that by a 21st century physio.
But do you think with that stance, which I would say is a good stance on tape, then you're going to be swallowed by those tape companies which are just pushing, this is your intervention for everything, this is what you should be doing? Or are you...
We'll see.
Are you finding your gap in the market as the ethical use of tape?
I'd really like to think so. I think that we're trying to drive that sensible use, that graded use of it, not seeing it as something that people should come to rely on. We're one of many tape companies. We're pretty much the only one that has penetration into a CrossFit world, and I think CrossFit's worth highlighting as a high usage market. People do some pretty silly things with their body and induce a lot of fatigue and pain, and therefore they use a lot of tape. But it is one of those ones where it kind of crosses between a clinical need and a kind of fashion statement. The kind of commercial and owning a share in a business says tape on, folks, but the clinician in me says, think about what you're doing a little bit. So I'm torn a little.
Yeah, it's a tricky one, and it's an ugly world when money's involved, and we know that. And running a business myself, it can get awkward. Rocktape, like any company, need to make money. We'll understand that. Do you think that as a brand you could market the product without the sales spiel that rubs some people up the wrong way? Must boundaries be pushed? I mean, we read from the box, we've mentioned the leaflets. You could say it's on the change, fair play. Is that feasible?
I'd like to think so. And with the limited influence I have over a company which is essentially a worldwide one, I do what I can to push for as sensible a message to be given as possible. Could we do it better? Yeah. I don't love every word that's written on the box of tape, but I do love every word that's said within our education program, because that I can control, and that's where clinicians get their key message about what it's for and what it's not.
Yeah, I mean, in general, when it comes to this, as what Rocktape puts out there, and what they do as a brand, do you find yourself cringing or being proud?
I cringe at 2%. I'm massively proud of how we've managed to change stuff, certainly just with our little efforts in the UK market, but more globally and bigger picture within worldwide taping education. I think that Rocktape really does present a different view and a fundamentally more evidence-based, scientifically plausible and rational side to how tape should be used.
Thoughts on that, Paul?
Yes, I agree with Paul's stance on it. I think the reality of the situation, the reality of the market out there is different from Paul's ideological, ethical point of view. I don't see Rocktape being much different from any of the other tape companies out there, in that they need to push this product. And I think in order to get market share, they need to push it more than just offering the small amount of intervention that clinical use would.
I think that's difficult, because that sort of, I mean, it makes me fear for my business model, certainly. You could argue that the little things done well in future volume would then stand firm compared to those in the short term that go hard and then fall short. So realistically, it could, and the only way to see it hold water is for it to be given a go. We'd sooner rather that than Rocktape completely sell out, wouldn't we?
Yes, definitely. But then, are they going to be superseded by the less ethicous companies who will just push a product?
What? And then we would mourn their loss. So we'd look back and, do you remember when Rocktape were talking sense?
Yeah.
So realistically, we should get behind them, shouldn't we?
Will they start to fall prey to the marketing strategies out there by less ethicous?
Someone like you at the helm, do you think that would happen? Do you think it'd cave ethically?
I've got one hand on it.
Yeah, helm's silly, isn't it?
Yeah. It not under my watch. Tape is not heavily advertised. We don't have a huge budget that we spend on putting colour page adverts in the Sunday Times. We're just not that size of a company. I think people overestimate the size of the industry overall and the amount of money that's being made out of tape. We're a relatively small company. Most people come looking for our product and search us out rather than get it pushed upon them. We're just not at that size where there's a huge amount of advertising going on. There's branding, sure, and a lot of people will see us as standing a little bit different to most generic roles of kinesiology tape. But it's not a massive part of what we do.
If I was to put to Paul Westwood, would you like to explain to the listeners where they might find more of your work? Anything else you'd like to plug or thank?
You can find me on Twitter, Paul Westwood at Triathlon Physio. Feel free to message me if you have any questions, anything that came up on this, you want to pick my brain even more, then feel free to message me on that. I'm happy to chat and continue the discussion. It's all about learning and critical thinking. If you want to investigate the team more, that's JFT Racing.
And there's obviously the now famous Skeptic blog that you wrote for Tom Goom's site. Of course, we will be plugging that on the show notes newsletter, as well as some of the resources that you kindly shared.
I have an old blog which I might start another thing which I started writing a few years ago, or even longer than that. So
out from the depths.
I started writing, Yeah.
We've got the cogs turning again, Paul, have we? Nice. That's what we like to hear. And then Mr. Coker.
So people can find me on Twitter at rockdoc UK. My email address is paul@rocktape.net, and the Rocktape website address is www.
Just two W's.
Just two W's. We are
it's such an innovative company.
We like to stand out in the crowd.
They've made their own internet.
We've reinvented the internet. I think it's going to be huge. It's www.rocktape.net. And anybody in the Cornwall in the southwest, they can find me in practice down in Truro at the treatment centre, and the website's just thetreatmentcentre.co.uk.
Wow, that was session 12 and our first Physio Matters debate. Many thanks again to the two Pauls for meeting me for our chat. As with every topic covered on the Physio Matters podcast, we want to present opinions, explanations, theories and the evidence in order for you listeners to make up your own mind. If you have decided that you would like to give K-Tape a go, then we think that you should spend less money doing so. And so the kind folk at Rocktape UK have set up a discount code which is ChooseHealth, all one word, all lowercase, to get 40% off tape, which equates to around £5 off a standard roll. Also, as you heard from Mr. Coker, Rocktape promote the sensible use of tape on their courses, and so if you would like to learn more, then do so for a bargain with discount code ChooseHealthEDU, again all lowercase, all one word. That gets you 20% off course fees. All products and education seminar listings are at www.rocktape.net. Finally, for a little summary from me, in general, I can draw a lot of parallels with Paul Westwood's approach to physiotherapy and rehab, fairly consistent with mine. Our words, our actions and our interventions have significant influences on our patients. However, as a sensory feedback tool that may help to neuromodulate pain, I can certainly see that tape has a place. Where all three of us agree is that the delivery of the intervention is hugely important. If you play its effects down, help patients to understand that it's facilitatory to movement, and always remind patients that they're not fragile, then I think we're still winning. As ever, thanks a lot for listening. Hope you've enjoyed it. To find our podcast guests over on Twitter, you've got at Rockdoc UK and at Triathlon Physio. That's for the Pauls. I'm at choose_health, and the podcast team, much wittier than I am, they tweet from at TPM Podcast. And what we've also got going on Twitter at the moment is your chance to win one of 3 rolls of free rock tape through a caption competition. So if you're quick, you can get on there. We'll be announcing the winner about a week after launch of this podcast. We have loads of resources to share with you for the show notes newsletter this month, so sign up if you haven't already, choosehealth.co.uk, and there's a podcast page that will take you through at the bottom of the page to the show notes newsletter, which has a Google Drive page link that takes you through to all reference material from all of our podcasts. And the last thing as ever is the usual sign out with the Pauls, and also a bit of cheese banter from Mr. Coker to finish us off. Thanks a lot. We'll see you next month.
You've been listening to the Physio Matters podcast,
discussing physio matters because physio
matters. Hey Jack, can I tell you a cheese joke before I go?
Go for it.
Did you hear about the man who painted his wife with cheese twice?
No, what happened?
He double Gloucester.